to the second day of Science Academy's lecture workshop titled Current Trends in Brain Development and Behavior, conducted by the Indian Academy of Sciences, Bangalore, Indian National Science Academy, New Delhi, the National Academy of Sciences, India, Allahabad, in collaboration with Union Christian College, Alva. We begin today's session with Dr. Rajani Ramachandran, Assistant Professor of Psychology, University of Calicut, on the topic Autism in the Mind, Neurodiversity Perspectives and its Relevance, Part 1. Dr. Rajani Ramachandran had the distinction of being the first rank holder in both her graduation from University of Kerala and post-graduation from University of Madras. She completed her PhD from University of Nottingham, UK in 2007 with her research specializing on autism spectrum disorders. She began her academic year from University of Nottingham and is presently a member of faculty at University of Calicut. She has won a number of awards and fellowships, including the Commonwealth Scholarship, the Indian Psychological Association, and Madras Psychology Society Award. She has published several articles in well-rated peer-reviewed journals and presented her research work in conferences in India and abroad. She is indeed the ideal person for today's session. We will now be moving to the speaker session. I would like to remind the participants that they should post their questions in the comments section for the speaker to respond. You may post your question while the speaker is speaking and need not wait till the end of the session. You will also find a link to the feedback form in the comments section. Kindly fill in the form and submit. Now, I welcome ma'am to begin the session.
Good morning, everyone. I'll first share my screen. I hope my screen is visible.
Yes, ma'am, yes.
Okay, so Happy New Year to all of you. Hope all of you are excited about 2021. I'm sure something good has to come up this year. It's long overdue. Before I begin, I would like to express my gratitude to the organizing committee for giving me this opportunity to begin the year talking about something which I am very excited about to all of you. So the title of my talk is Autism in the Mind, Neurodiversity Perspective and its Implication. And the talk continues over 2 sessions, but it's a single talk. And in this session, we will be looking at what autism is very briefly and some of the main psychological theories of autism. I will end the session by putting across 2 broad orientations through which we can look at the various characteristics of autism. One, a deficit-based perspective, and the other, a difference-based perspective. So let me begin by looking at what is autism. Autism is defined as a neurodevelopmental disorder, which basically means that there are differences in development of the nervous system of children who have autism. And this influences the child's development in various spheres. Anatomical differences in the brain have also been identified. And these include the cerebellum, the brainstem, frontal lobe, the parietal lobe, the hippocampus, and the amygdala. However, the cause is not yet known, but a strong genetic link has been strongly identified, which basically means that there's a higher concordance rate between biologically related individuals as opposed to the general population. Also, it is seen that greater the percentage of genome shared with an autistic parent or a sibling, higher the probability of being autistic. However, that one single gene which may be responsible for causing autism, like you have in Down syndrome, has not been identified. Neither has it been possible to identify a cluster of genes which has been consistently seen in all people with autism. So the current understanding is that it is multigenic and heterogeneous in nature. So the diagnosis, as is the case with most psychosocial disabilities, is based on behavioral manifestation. And the DSM-5 clusters the various characteristics that autistic individuals show into two. One is difficulties in social communication, and the other is difficulties in restricted repetitive behavior or interests. Now, autism was first introduced into the diagnostic category in 1980 with DSM-3, and in DSM-4 in 1994, it was included as a spectrum of disorders. However, this idea of spectrum has been removed in the current classification, but there is a general consensus that there is a spectrum when you look at autism. So we do not have that single cause. So basically, we make the diagnosis by observing the behavior of the child. And this is a awareness poster. However, I have included here because I want to bring this poster back later in session 2, or maybe at the end of the session itself. And I would just like you to keep in mind, like, because there's so much of information, couple of aspects which are characteristic of autism, like inappropriate playing with toys, inappropriate laughing or crying, difficulty dealing with changes to routine. And we will look at these again. Now, though this is an awareness poster, these are the same characteristics that a clinician would also try to look at. For example, the MCHAT, which is one modified childhood autism test, asks the parent. It's a parent interview schedule which asks parents, like, does your child enjoy playing peekaboo? Does your child appear oversensitive to noise, etc.? Or CAST, childhood autism rating scale, ask the clinician to observe the child's interpersonal interaction, communication, etc. So autism is a neurodevelopmental disorder. There is a strong genetic linkage, and the diagnosis is made behaviorally. The fact is that we haven't got that one gold standard for all three areas, be it brain, be it gene, be it behavior, to make clear, etiological identity for autism. So as psychologists, what we do is try and identify whether there are cognitive differences between people who have autism and who do not have autism. This basically means whether people with autism process information in a different way than, or does autism lead you to process information in a different way. And a large number of psychological theories have been put forth, and I will be taking you through some of these theories with a specific intention. So I am not going into details of any of the theories, but just a brief overview. One of the first theories is the theory of mind hypothesis. Theory of mind is a term put forth by Primack and Woodruff in the article, Do Chimpanzees Have a Theory of Mind? And theory of mind is defined as the ability of individuals to impute beliefs, desires, intentions, and other mental states to themselves and to others. And we do that in order to predict and explain behavior. Terms like mind reading, mentalizing, propositional attitudes, etc. are also used, which basically suggests that we are taking into account aspects that are not observable and using them to make the predictions. So this particular, and it is seen that children as young as 8 months are showing precursors to the development of theory of mind. They are able to understand another person's desires and intentions, and slowly they develop an understanding of beliefs, emotions, so on and so forth. So over a quick period of 3 years, children show increasing sophistication in their understanding of other minds. And so we are able to understand this cartoon that I have put in the slide, basically because we have a theory of mind which makes us understand that that last square of the cartoon strip is funny because both Heathcliff the cat and his owner John are having this funny grin because both of them are hiding some information. Heathcliff is also showing elements of theory of mind, where he is wondering if John has a particular information in his mind, and John also showing theory of mind ability. So, Simon Baron-Cohen and colleagues in 1985 suggested that people with autism have a theory of mind deficit. They have difficulty inferring mental states like beliefs, desires, etc. of others. And this can be used to explain many of the characteristic autistic features. So what I mean, that is a series of really well done and interesting experiments from 1985 onwards, and the research into theory of mind continues. But basically what this means is that so suppose I am writing something here and the bell rings in the front door, and I drop my pen and run to see who is at the front door. In the meantime, maybe my pen rolls and falls down, and I come back and I start searching. And you would, if you are in the room and you do not have autism, the chances are that you would immediately infer that I am searching for my pen on the desk because I am on the false belief that the pen is still on the desk. I do not know that the pen has rolled over. I haven't seen that. But research from Baron-Cohen and others suggests that people with autism do not have this mind reading ability, and as a result, they will not understand why are you searching, and hence will not point out to the fact that the pen has rolled down and is there on the floor. And this particular hypothesis has been used to explain characteristics like deficit in joint attention, which basically means that two people can direct their attention at the same thing. So if I hold up something and I ask someone to look at it and the other person is looking at it, I understand that both our attention is on the same object, and now we can have a conversation about this object. There is also difficulties with pretend play, which is also explained by theory of mind deficit. People with autism have difficulties with understanding nonverbal cues. They have issues in carrying out social conversations, so on and so forth. So many of the features that is shown by autistic individuals are explained by theory of mind hypothesis. Second theory is the executive dysfunction hypothesis. Now, executive functioning is basically an umbrella term that is used for a large number of very important cognitive functions. So according to Hill, executive function is used as an umbrella term for functions such as planning, working memory, impulse control, inhibition, and shifting set, as well as initiation and monitoring of action. And in 1985, Judith Ramsey suggested that, or did a research which suggested that people with autism may be having frontal lobe dysfunction. So some of the characteristics which are shown by people with autism, like a need for sameness, difficulty switching attention, tendency to perseverate, and a lack of impulse control are also shown by individuals who are now known as to have dysexecutive syndrome. And this is based in the, or this is the result of frontal lobe damage. So, but many of my students would be or many of my students would argue that more than executive functioning, to get in assignment on time, maybe last minute panic is more useful than executive functioning. So anyway, in the case of autism, Oznoff and colleagues, based on a large number of tests which involved many different kinds of neuropsychological tests looking into frontal lobe functions, suggested that behavior like perseverative behavior, routine adherence, etc., are a result of impairment in executive functioning. So autism is an executive dysfunction. Third theory is the weak central coherence theory. The typical way in which, or the way in which neurotypical individuals would process information, be it social information or visual information, is look at the overall picture. And this is called, global precedence, central coherence, etc. So we do not see individual trees, but we see forest, right? So that is how a neurotypical individual is known to process information. It is not that the other one is not possible. It is not that we are not able to see the individual parts, but the default way in which you process information is by looking at the global rather than the local. So we are able to understand this particular cartoon because we understand that the word horn can have two meanings. One, the horn of the animal, and two, the horn of the car. So cows have bells because their horns don't work is hence funny, or we understand the pun. In using even sentences like these and other visual tasks, Amita Shah in 1983 suggested that autism shows a specific cognitive style where people focus on the detail rather than the bigger picture. So they would see the trees rather than the forest, or they would not understand the pun because the context in which the word horn is relevant may miss them. And this is seen as a positive theory, or the first positive theory, because you are not talking about it just in terms of deficit, though we are using the term weak central coherence. But it was used to explain some of the strengths that are seen in people with autism, like very good visual memory, very good performance IQ, etc. It was also able to explain some of the non-social aspects or non-social difficulties or non-social characteristics that autistic individuals show that theory of mind and executive dysfunction was not able to explain, like fascination with parts of objects. So if you remember, there was this playing with odd way of playing where the cards are arranged in a particular way, or the child is interested in just the wheel of the car rather than the whole car. Also, the restricted interests, etc., are explained by this hypothesis, the weak central coherence hypothesis. Now there are other theories. These three theories, the theory of mind hypothesis, the executive dysfunction hypothesis, and weak central coherence hypothesis, are the three major theories or cognitive theories of autism. But other theories have also come about as a result of modifying, trying to explain aspects that the initial theories were not able to explain, so on and so forth. But you will see that these have, in some way or the other, a relation to the initial classic theories that I spoke about. So social orienting deficit theory, which is put forward by Geraldine Dawson in 1988, suggests that autism is a failure to spontaneously orient to naturally occurring stimuli in the environment. So people with autism are not going to look at social, or are not going to be attentive in a spontaneous way to social stimuli like faces or people, etc. And that first thing that you need while you are attending to another human being spontaneously is not happening, and that is seen as the result of why there is a theory of mind deficit, etc. Simon Baron-Cohen also put forward another theory, which is called the empathizing systemizing theory, and this was put forward in 2009. And Baron-Cohen talks about two ways of interacting with the environment. One is as an empathizer, and the other is as a systemizer. So empathizers are really good with social systems. Empathizers are good at understanding others' emotions, feelings, etc. Interacting with many individuals, getting people to work together, like any kind of social system is something where empathizers are comfortable. As opposed to empathizers, you have systemizers who are good with systems that are non-social in nature. These can be geographical systems, these can be computer systems, these can be electrical systems, where there aren't any social components involved. And Baron-Cohen suggested that autism is a result of a very grave discrepancy between empathizing and systemizing. So people with autism are extremely good at systemizing, but extremely poor at empathizing, whereas the neurotypical individuals come, the discrepancy is not all that high. He went on to suggest a theory called extreme male brain theory, which says that this discrepancy between empathizing and systemizing is seen even in is a male pattern, a male brain pattern, as opposed to a female brain pattern who are more empathizers. The higher systemizing thing is something that you generally see in the male population, and autism takes it a step further. Of course, there are a lot of critiques, etc. But Baron-Cohen has given evidence based on hormonal testosterone level in the womb and things like that. Now, apart from these theories, you also have specific brain-based theories like the social motivation hypothesis, which is put forward by Chevalier, etc. The idea behind social motivation hypothesis is that children with autism do not find social interactions as rewarding as their neurotypical peers. So the interaction itself, we would engage in social interaction. We as a neurotypical individuals would engage in social interaction because we find it rewarding, and we can see this reward in the way the brain is processing information. So you would see less reward-related brain activity for social stimuli in people with autism as opposed to neurotypical individuals. The intense world hypothesis speaks that certain areas of the brain are overreactive. The areas that have come up are prefrontal lobe and the amygdala. And this leads to many of the issues, sensory issues, especially that autistic individuals face. Of course, when I'm saying that these social motivation and intense world hypothesis are brain-based, the idea is that the theories were brought about based on brain studies, based on neurological studies. The other theories, cognitive theories, began by conducting cognitive psychological experiments, but later there are studies which are using fMRI, etc., that suggest that the theory of mind system in the autistic individual works differently, or the weakness in the central coherence is also seen in the brain, so on and so forth. Okay. So, but anyway, the search for a unifying theory, a single theory, continues. But that search was very strong in the 1980s and 1990s. Now you see a little dampening in the research. It is there, but it is not, the thing to work in. Basically, because I think the only consistent finding that has come out in all these research is about how heterogeneous the nature of autism is, right from genes to your brain to your behavior. So where does that leave us? We now know that autism is a lifelong condition. By lifelong condition, what I mean is that there is no cure, and it is a very complex condition. So that one cognitive theory, gene or brain network that can explain autism has been elusive. Neither have we identified that one behavior which is seen across all individuals with autism. Of course, joint attention was seen as like the acid test, the litmus test for autism diagnosis, but even that you don't see it. If there is a deficit in joint attention, you can be very sure that there is autism, but there are people with autism who or parents who report that their child does not have a deficit in joint attention. They are pretty okay with showing bringing objects of interest, so on and so forth. So where does that leave us if we don't have that characteristic, that cognitive theory to explain? Two things are there that can be done. One, we try to fix the child one behavior at a time, looking at the individual child, looking at the individual behavior, so on and so forth. Second option is to look at these deviations as normal differences in the larger scheme of things. So these are not deviations. So it is not a theory of mind deficit. It is not an executive dysfunction or weak central coherence, but rather a different way of interacting with the world than what is the default mechanism or default non-autistic mechanism. And I am going to argue for the latter. But what is the larger scheme of things is a question. So the larger scheme of thing in this particular talk is going to be two aspects. One is the implication for or the need to have a diversity perspective when we provide psychoeducational support to autistic individuals. And the second larger scheme is how does the diversity perspective support the cause of social justice, the cause of the rights of individuals with autism. And in this, it is in the second part, in the second aspect, that I would like to bring in the relevance of the neurodiversity perspective. The neurodiversity, just to bring it in context, basically argues that many of the neurological conditions are normal variations of the human genome, and these variations are still there in the population because it has an evolutionary advantage, and they are not pathological. We will go into more details of this in the second session. I just want to tell you that in the second session, we are going to look at why diversity perspective, or why in terms of this two larger scheme of things. And also I would like to bring in a few thoughts about the Indian context. This is going to be in the afternoon, but before I just want to conclude by looking at this poster again, which is about the signs of autism. Like I told you, this is an awareness poster, and this poster was developed by I mean, not this poster that you see on the screen. The earlier poster that was shown was developed by clinicians, and the same poster was then given to parents, and they were asked to whether they would like to change anything about the poster, or how would they put forward the various characteristics that was talked about. And this is the poster that these are the wordings that the parents, of course, the parents are definitely well informed parents, but what they have used is an entirely different kind of wording. So if you remember in the earlier, like I have starred some of the items that I had asked you to attend to earlier. For example, there was inappropriate laughing or crying. And instead of that, the parents have used the term finds different kinds of things delightful or frustrating. And playing with toys in ways that don't make sense to others is the term that the parents used instead of what they I think they had used difficult, what was it? Yeah, instead of inappropriate playing with toys, the parents use playing with toys in ways that don't make sense to others. And sticking to routines, parents have used the term wants the world to make sense. So one can argue that this is a more romantic way of looking at autism rather than the reality. But I would like to argue in the next session that this isn't really romanticism. Whether we take a deficit perspective or a different perspective has huge implications, both from the psychoeducational support that we provide autistic child and adult, and also how we lead the society to perceive people with autism. I will stop there, and I'm ready to take questions.
Thank you, ma'am. Now it's time for the question answer session. Ma'am, we have not received any questions yet.
Okay.
So participants, I kindly request you to post your queries if you have any into the comment section. And ma'am, we'll wait for a few minutes if some participants would like to ask any queries.
Fine.
Ma'am, the first question has come from Dr. Manju. The question is, at what stage of development will we be able to identify that children as autistic?
The requirement is that the diagnosis happens before 3 years of age. The diagnostic procedure or the diagnostic testing procedure is becoming more and more improved with the age, with time. So now you have for example, by 18 months the joint attention should be there in children with autism. So you may want to wait till then to give a diagnosis of autism. But whether the child is susceptible or at risk, which is the term that is often used, can happen much earlier. So you have ways of identifying even by first year. The problem is that in Indian setup, we do not have this well baby clinic where you're also looking at the development or the cognitive development of the child. In the well baby clinic, in Indian setup, we are only looking at the physical development and things like that. So often we miss out babies who are at risk, but the autistic feature should be there before 3 years of age. Whether we are able to identify them before that or not is another matter.
Thank you, ma'am. The next question is from Chandrama. The question is, can children and adults seem neurotypical and be atypical, actually?
The way I am understanding the question is whether people who do not have any neurological impairments can also show atypical behavior. I think in like yesterday's sessions, there was a lot of talk about the amount of neural plasticity, etc. And it's the same thing. There's so much of diversity. The reason we have not been able to identify that one neural system, which is a clear indication of autism, is also because of the diversity at a neural level itself, right? So we cannot check whether for any person who is showing anything that is beyond what would be labeled as normal has a neurological deficit. So like it is not such a clear-cut link between the brain, the cognitive processing, and the behavior. So the idea of neurodiversity is that we might as well do away with the concept of atypical unless there are some dire straits. I didn't hear.
Meghna, you're mute actually.
Sorry. The next question is from Justin. The question is, should autistic children be sent to regular schools which may not address their special needs?
The present idea is about inclusive education, not just integrated education, but inclusive education, which theoretically and ethically is something we really need to push towards. However, what I have observed and what I have heard from parents is that Justin Jose has rightly shown, that the needs are not really met for various reasons. There's lack of training for teachers, there isn't enough support system, and even we do not know how exactly to carry on an inclusive school. So should they be sent? They should definitely have that option available to them. But I think what is also important is that various options are available to them. So because if we are talking about neurodiversity, it also means that we also allow them for a lot of diverse options. So from an inclusive point of view, if a child with autism and his or her caregiver would like to take access of a regular school, they should definitely be given access to a regular school. But if they feel, and they should be given all the support that is needed for them to be able to do well in that school. But if not, if for whatever reason the child would be better off in a specialized school that caters to the specific needs of people with autism, then yeah, that option also should be available.
Thank you, ma'am. The next question has come from Adarsh. The question is, will the definition of neurotypical be dependent on the need of the society? With jobs like programming being more mainstream, can being autistic be seen as an advantage?
Yes, I will be going into more details about this in the second session. Will the definition of neurotypical depend on the need of the society? I don't think it depends on the need of the society, but yes, there is a lot of cultural differences or cultural aspects that influence how we look at autism, or what are the features of autism that come to the fore. For example, it is seen that we do not identify deficits in pretend play. At least the parents don't identify that deficit in the Indian context, as opposed to the Western context. Or pointing. There is a question which talks about does your child point at objects? But then in the Indian context, maybe the situation is changing now, but earlier pointing at someone or pointing at someone especially was not considered to be a appropriate behavior, right? So, and under those circumstances, the diagnostic categories will show an influence of culture. What is also seen is that the specific, it is not whether it's a need of the society, but specific aspects of autism are seen as more problematic in certain culture. So the social aloofness is, or the behavioral manifestation of stimming, etc., may be more difficult in a collectivist society like ours, because we need to conform more. But I don't know what exactly is happening with adults with autism or teenagers with autism in the Indian setup, but given the fact that in the West there is a very strong need for adolescents to have relationships, the social aspects of or the social difficulties that they face have a very strong implication in the West more than, say, in India. So that kind of differences, cultural differences, you do see. And the advantage part, we will be going into details in the next session.
Thank you, ma'am. The next question has come from Jaran. The question is, has COVID pandemic period addressed autistic children's issues with attention?
There has been a lot of very quick research which is coming up that shows that as a result of the COVID pandemic, people who have children with various disabilities, including autism, do have special issues. What I know in some of the things that I know that has been happening is where, for example, the Sarva Shiksha Abhiyan in Kozhikode, which has an autism resource center, has been keeping in touch with people with individuals, parents of children with autism over the whole course of the pandemic, and providing support through telephone, and addressing specific issues that they're facing, as well as counseling the parents. They have also had some have attempted to have therapeutic sessions, or like the educational training sessions through WhatsApp, because That was the more than Google Meet, etc. WhatsApp is something which is more easily available to most people with autism. I mean, most of the parents. Also, at the University of Calicut Psychology Department, they were having the CW. There is a project which has also been in touch with people with parents of people with disability. So, but I think one thing the COVID should teach us is how important it is to have a system in place where the support is provided under such circumstances. And I am sure there are some research, but not so much from India. But I wouldn't be at all surprised if you find that those parents who are more empowered, not just in terms of financial aspects, but in terms of being able to connect with their child and provide services themselves, which is what usually happens, have been able to better deal with the pandemic. So, yeah, it has been done to the best of the capabilities that we have now, but is it enough? I guess not.
Thank you, ma'am. The next question has come from Justin. How does an autistic person change over age? Is there a possibility of improvement in cognitive functions?
There is a saying that autism affects development, and development also affects autism. So yes, we cannot make predictions about how a person with autism will be based on his or her functioning when he or she is a child. For example, there is a person called Temple Grandin, who is a professor of animal sciences at University of Colorado, a very well-known person who has autism and who is an advocate for neurodiversity also. If you read her autobiography, you realize that she had severe difficulties, sensory issues when she was a child. And many of the autobiographies, or if you talk to many of the parents, often they are told that this is like the end of the world, having a child with autism. Hopefully it's changed now, but yeah, ages back, and when you look at the autobiography, that seems to have happened a lot. So as a result of development itself, there is a lot of change that happens to people with autism. Or what are the features? Features may come and features may go. The severity will go up, severity may come down. There may be periods during which there is intense difficulties. All that is there. So, and with good support, with good psychoeducational support, there is a huge amount of promise for anyone who has a diagnosis of autism. So yes, it does change, and it changes for the better.
Thank you, ma'am. The next question has come from Dr. Pisharidi. The question is, ma'am, how will you explain the following? Once the diversity perspective has been accepted, many still fail to conform to the social norms, and even 1/3 of the people are intellectually disabled, and even 1/3 have seizure. So many need significant support for a normal life. Ma'am, how will you explain these?
I hope to go. I hope that in the second session I would be able to argue for the neurodiversity perspective and the fact that the idea of neurodiversity, just quickly, just a quick statement here, is that the idea of neurodiversity is not saying that you fix the child. And it is not about saying that people with autism have superpowers, or that they can be, given their special skills. They can actually contribute to the society. All that is also part of the neurodiversity perspective, but the general idea is that there are variations in the population, there are differences in the in individuals, and it is about accepting these differences and the fact that people can contribute meaningfully to the society irrespective of these differences. The fact that there is a group of people who are or who are average autistic, or who have comorbidity, is also part of that whole system. And I hope to go into more details in the afternoon session, and still support argue for the neurodiversity perspective.
Thank you, ma'am. That was the last question that we had received. Thank you everyone for your active participation in this informative and very useful seminar. We have reached the end of today's session. I thank you, ma'am, for this wonderful and informative talk.
Thank you.
Now I call upon Ms. Anjali Verma to take over the next session.
Before we begin with the next session, I would like to remind the participants that they should post their questions in the comment section for the speaker to respond after the session. You will also find a link of the feedback form in the comment section towards the end of the session. Kindly fill in the form and submit to ensure that you receive your certificates. We shall now have our second speaker for the day, Mrs. Annamma George, speech language pathologist and audiologist, who has held the position of speech therapist in the Department of Neurology, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Thiruvananthapuram. She has completed her bachelor's and master's degree in speech and hearing, securing the first rank for both, awarded by the All India Institute of Speech and Hearing and University of Mysore, respectively. Having worked as the honorarium consultant speech therapist in Abu Dhabi, ma'am has also been part of several projects like prevention of deafness and hearing impairment, and an epidemiological survey of developmental language disorders and learning disability among school children in Kerala. She has also completed an independent project titled A Follow-up Survey on Users of BTE Hearing Aids, submitted to the University of Mysore. Having conducted several researches, publications and paper presentations, ma'am has also held various professional positions like Chairman Scientific Committee of the Kerala Chapter of the Indian Speech and Hearing Association and Editorial Board Member of the Journal of the Indian Speech and Hearing Association. I welcome Mrs. Annamma George for the session.
Hello.
Hello, ma'am.
Yeah, can you see my slides?
No, ma'am.
Just a minute. Now?
Okay, ma'am, it's coming. It's coming.
I'll just put it on slideshow. Just a minute. Hello, can you see my slides?
No, slides is not shared yet. We can see your screen.
1 minute. Now, can you see? Hello?
No, ma'am.
I think I'm having the same problem like yesterday.
First you try. Okay. Now
It's
it's
come
there.
now?
And choose your file which you want to show. Actually,
That has not come on.
no, the slide is not here. We can see your screen. So select the PPT. So it will open.
Has it opened?
No, ma'am. Please double click on the file. Brain and language. Yeah.
Yeah, I did double click on the file, but I don't know
Please try
why.
again. It will come.
Has it come now?
No, ma'am.
I'm not able to. Actually the share is not. Yeah, now it may come. Check.
Okay, it's coming.
Yes, it's come now.
Yeah. It's fine.
Okay, fine. Sorry for that glitch. Okay, can everybody hear me? Hello?
Yes, ma'am. You are audible.
Okay, have I gone live now?
Yes, you're live.
Okay, fine. So good morning, everybody. At the outset, I would like to thank the organizers for having invited me to give this talk. Probably through the course of this 1 hour, what I would like to actually say to you is, I will be talking about certain aspects. One, basically about the brain and what are the areas that are involved in language processing. And also I will be talking about the aphasias and the dementias and what are the language problems encountered in these groups. I would also like to briefly touch upon clinical assessment and what we should take care during the time of assessment and the future. I would also probably be touching upon the certain terminologies which you would come across language. I'm specifically doing this because, as I understand, today's audience is a very mixed group, and very across and many a time you come across a lot of research papers, and you find these terms which are used there, which many of you will not be sure of or have an understanding about. So before I start, I would like the audience, especially those who are professionals or seniors in this group, to bear with me because I am going to take you across the small journey of a little bit of neuroanatomy, which will all of you are already familiar with. But because we have the undergraduates also here, I will just touch upon these areas just to recap on some of the aspects. At the same time, I would also want to specify certain areas of importance for language and what happens when there is damage in these areas. What do we see it? What do we see it as outside, or what are the syndromes that we see, or the disorders that we see, are certain things I'd like to touch upon. So I think you've gone through a series of lectures yesterday also, and a lot of people did talk about the evolutionary process. And you know that our brains are different. The human brain is not only structurally, but even it is wired differently. And we are endowed with the gift of speech, with the gift of communication. And it makes us different from animals because we have a superior communication system in terms of language. And also we are endowed with bigger brains. The size of the cerebral cortex is large. And these aspects which you already know about. So the areas that are dedicated to language are much more in the human brain. So these aspects I will not be going through, but just for you to just think about the cerebrum, brainstem, the limbic system, the cerebellum, the association areas, the cranial nerves, and the pathways, some of which was touched upon yesterday. So all these things are involved. We know that at birth, the children have around 10 billion brain cells and a lot of patterns and pathways which are already established. But during the developmental process, something happens to the neural brain, and the processes that takes place are the growth, maturation, and learning. Now, I would be specific about the first 3 years of life because a lot of development, both in terms of motor and in language, takes place at that time, isn't it? So the first 3 years of life is extremely crucial. Now, since it's not an interactive session, I'll be doing the questioning and the answering by myself. So what happens? How many words does the child say at the first year of life? Usually, it is only one word. Okay, unless the child is very, very. There are children, some of them who are a little superior. They may say a few more words, but the general pattern is the child should have said the first word by his first birthday. What do you expect by the second year of life? By the second year of life, the child has started putting words together, making phrases, but the vocabulary would have increased to around 50 words. But by the third year of life, it's a tremendous increase. Where we started off as one word in the first birthday, by the third birthday, the child would have learned 300 words. So there's an extremely fast developmental process that is going on in the brain, networking, and a lot of connections being established. And if there is any kind of problem within this first 3 years, so that a child encounters some insult or damage or some infection, we see that the language development is delayed. Similarly, there's another concept which is a critical period for language development. And here what we see is that there is a certain age for language learning, after which it is not possible. What researchers have found that it's difficult to learn a new language after 16 years of age. So if somebody learns a language a second language between 10 to 16 years, what was seen when compared to typically developing native speakers of that language, it is always different. They do not have the proficiency of the native speaker. Now, we all know that behavior, including the cognitive process, are mediated by the brain and the central nervous system and the supporting physiological system. Now, if anything, like I said earlier, if there's any disruption in this process, that is when we see the deficits. And these deficits are seen as the behavioral deficits, which the individual presents with. So for a quick recap of the anatomy, we know that the central nervous system includes the brain and the spinal cord, and there are around 10 billion neurons. Now, the outermost surface of the brain is called the cortex, and it has a folded mass of hills and valleys called gyri and sulci, which you are aware of. And the cerebrum is divided into two hemispheres, isn't it? The right and the left, and this is by the longitudinal cerebral fissure. At the top of the brain, there's another fissure that runs laterally downward and forward, and this is the fissure of Rolando. Now, this fissure of Rolando divides the brain into the anterior and the posterior halves. At the lower inferior frontal lobe, at the base of the brain, there's another fissure which moves laterally and upward, and it's called the Sylvian fissure. Okay, so you can see in this picture. Is it visible? Can you all see the picture? Hello?
Yes, ma'am, we can see it.
Okay. Okay, so this is the Rolandic fissure, and this is the Sylvian fissure. Okay, so these fissures are important because they will tell you where the lobes lie. So we all are aware that there are 4 lobes, isn't it? The frontal, the parietal, the occipital, and the temporal. Now the frontal lobe is extremely important for speech production. In the frontal lobe, in the front of the central cell is the precentral gyrus. Now, that houses the primary motor column. Now, why that's important is it controls the voluntary movement of the skeletal muscles on the opposite side of the body. Now, this is why I'm saying this specifically is when a patient develops stroke, usually when they lose the ability to speak or they develop aphasia, we see that they develop paralysis of suppose the stroke is on the left hemisphere, they develop paralysis of the right upper and lower limb. Or it may either be a paralysis that is a hemiparesis, or they can have a hemiplegia where the both right up and the right upper and lower lip are affected. So this picture, see, it's self-explanatory about the 4 lobes. You can see the frontal, the parietal, the occipital, and the temporal. Okay. Now, the frontal lobe is considered to be the seat of highest mental function. So, in evolutionary terms, it's the most recent to evolve, and it's the most recent one to evolve. And the man possesses very large frontal lobes. So you can divide it again into 4 parts. That is the motor and the premotor. We spoke about the motor, the prefrontal, the Broca's area, and the orbital. Okay. So can you see the prefrontal, premotor, the primary motor, the Broca's area? Okay. So that is. So the motor cortex, it connects directly to the spinal motor neurons. Now, if there are lesions in that area, like I said earlier, there will be loss of control of precise area of the body. Sometimes, if the damage is very in very specific areas where the fine motor control of the body is there, we see that movements of the hands, the fingers, and the face will be impaired. There will be a reduction in the speed and strength of limb movements, and there's also difficulty with just a minute. Yeah, there's difficulty with verbal and design fluency and spelling. Now, in the prefrontal cortex, that's where the planning and coordination of motor acts happens and adaptation to a particular circumstance. Now, if there is a lesion here, the behavior here, you see that the individual's behavior is inflexible and stereotyped. So this area also contains the area for eye movements, which is important for scanning of environment and inspection of visual objects. And basically, there's reduced spontaneous behavior if there's damage in this area. Now, the Broca's area, like I showed you in the picture, it's situated in the left frontal lobe. Now, this is very important because its basic function is expression, how we speak, expressive speech. Okay. Then we have the orbital cortex. It's important for personality and social behavior. And if there's an impairment here or damage to that area, there's lack of social graces, lack of initiative, and indifference. Next, we move on to the temporal lobe. I'm going a little fast here because many of this or most of the things in this aspects you know, and you can also read up later. Now, the temporal lobe, now it is situated in the lowest 1/3 of the brain. It starts at the lateral fissure and ends at an imaginary boundary of the anterior portion of the occipital lobe. It lies under the frontal and parietal lobes, and it's in front of the occipital lobe. Now, the primary auditory area is at the border of the superior temporal gyrus and lateral fissure. It also houses the Wernicke's area, which is posterior to the primary auditory area. Now, this area is very important because it deals with receptive language. So, the basic role of the temporal lobe is auditory perception, higher aspects of visual perception and receptive language. It also houses the superior, middle, and inferior gyri and the Heschel's gyri. If there's a damage to this area, it may lead to auditory agnosia. In auditory agnosia, they may hear the sounds, but they're not interpreting the meaning from it. Okay. Next is the occipital lobe. Now, it's the posterior part of the cortex and is concerned with visual perception of form and movement. They are the cortical centers for visual experience. Now, the primary visual sensory cortex and areas anterior to this are the visual association. Now, all these association areas provide meaning to what we, in this particular case, it provides meaning to what we see. So, the association areas are the areas where we are, any kind of input that is given is understood properly only because of these association. Next is the parietal lobe. Now, the parietal lobe maintains the awareness of sensory phenomena such as temperature, pressure, texture, and tactile sensations of size, shape, and weight. It lies behind the central fissure and above the lateral fissure. Behind the central sulcus is the postcentral gyrus, and it is also called the sensory cortex or the sensory strip. So, this picture, can you see? Is it visible?
Yes, ma'am.
Can you see the picture? Okay. This is the Broca's area, the Wernicke's area, the other are the gyruses. Okay. So I'll show you another picture which will show you. So we have 2 more areas which we have to be, which we should know about. One is the supramarginal gyrus. It lies above the lateral fissure in the inferior portion of the parietal lobe. Why this is important is that if there's a damage to this area, it causes agraphia, or there's a difficulty in writing, or the patient may have conduction aphasia. We also have an area called the angular gyrus. Now, this lies posterior to the supramarginal gyrus, and if there is a lesion or damage to this area, there's difficulty in naming, difficulty in reading, and difficulty in writing. Okay, so can you see this? This is the supramarginal gyrus. Sorry. This is the supramarginal gyrus and this is the angular gyrus. Okay. Now, all of you must have heard of the term aphasia. Okay. So, what does aphasia refer to? It basically refers to a loss of language consequent to brain damage. Now, this brain damage can happen because of a stroke. It can happen because of a head injury, or it can happen because of some infection, or the patient can have a tumor. So, what happens is when there is damage, although the cause may be one, most commonest is usually stroke. And the patient has difficulty in speaking, or it may be in writing, or it is in reading. Okay. So what is language? Language basically is communication of thoughts and feelings through a system of arbitrary signals, such as sounds, gestures, or written symbols. Okay. And what does aphasia provide us with? When aphasia happens, it's a window on the relationship between brain and language. It gives us insight. It provides us with insight. So the first person to actually set the ball rolling is Paul Broca, and what he found was that in the patient the patient who had difficulty in speaking, he pinpointed that it is the frontal lobe and the left brain that was involved in that patient, and he is the first one to postulate that we speak with the left hemisphere. Carl Wernicke was also a major contributor because he's the one who reported about Wernicke's aphasia, wherein he felt that the receptive areas, so that is how Wernicke's area was named after him, and the Broca's area, or the speech production area, was named after Paul Broca. Okay, so what is the role of the Broca's area? It's important for serial organization and motor programming of language. So that is the area where there is a selection and ordering of semantic items which are necessary to express an idea and formulation of words. And appropriate neural circuits are activated so that motor organization takes place and the verbal message is put together along with adequate rhythm and phonetic structure. So the first or earliest descriptions of Broca's aphasia, they have developed they have described that these patients have no difficulty with content words. They have difficulty with function words. So basically, in Broca's aphasia, the patients have very non-fluent speech, halting speech. Okay, when you hear them speaking, you know that they stutter. It's like a stuttering quality. We call it a stuttering quality. Okay, it's agrammatic in the sense that they use only content words. What we mean by content words is, like for example, if you show a picture of a boy running or a boy eating an apple, the patient may only say boy apple. He will never say the boy is. So the and is are function words. He will drop the function words, and he has a tendency to only use the content words. So when only content words are there in a sentence, it is not grammatic, and it sounds very incomplete, and there is no fluency. Okay, so as you see in this picture here, this was where the patient with Broca's aphasia had damage. Now in these patients, what we see the Wernicke's areas, this areas and the auditory areas are intact. So in these patients, what we see is that they will be able to comprehend. Comprehension and reception are one and the same. Okay, if they are used interchangeably, that means understanding ability. So when you these patients are able to comprehend things. For example, if you say command, raise your hand, close your eyes, all this they follow. They may even do two states. Sometimes the patient will have difficulty with very complex commands. But basically, general conversation, questions being asked, all that is usually comprehended by these patients. And I told you where the damage is. It's in the left inferior prefrontal cortex. And the content and function words I already explained. So I'll move on to the Wernicke's area. Now, Wernicke's area is important because that's supposed to be the seat of the comprehension of spoken language or the understanding of whatever we speak. Okay, so if you are exposed to a language that you do not know. Okay, that is an alien language. You don't understand anything that is being said. So, but in patients with Wernicke's aphasia, it is like that for them. It's like as if you are speaking a new language because they don't understand what you're trying to say. Now, what happens is in the Wernicke's area, that is where meaning is attached to the phonological characteristics of speech, and the comprehension of the message takes place. So, can you see this picture? In this picture again, see, this is the area which shows in one case of aphasia, the patient has damage to the left the temporal lobe. Okay. Now, how is the patient's speech? In one case of aphasia, they're very fluent. Okay, because can you see here the Broca's area is intact. There's absolutely no problem here. So the patient is able to speak fluently. Only thing is when he speaks things which are probably like he speaks a foreign, because we are not able to understand the language that he's using. He has many self-invented words which are not in that particular language. So the speech is considered to be empty because there is no passing on of any information content. Okay, he's not able to communicate adequately what he wants. In his mind, he's saying things, like he can see his lips moving and the sound is coming out, and we are not able to comprehend what he's saying. In this patient, we see that the function words are preserved and they have difficulty with content words. They don't understand what we say, like even very simple commands, sometimes they don't follow. Now, in patients with Wernicke's aphasia, sometimes in the clinical situation, I'd just like to add this. In the clinical situation, when they come to the clinic and we talk to them, what happens usually is that when we ask them, what do you think about the comprehension aspect? Does the patient understand what is being said? They'll say yes, he's understanding this. Okay, but what we should remember is that it is the auditory modality that is compromised in these patients. Okay, so they will understand the visual modality. For example, if you go to the patient and say "Marunnu Kazhikka" with a glass of water, it is not because you are saying "Marunnu Kazhikka" or "eat the medicine" that the patient is responding. It is the visual cue in terms of the glass being there and the tablet being there that the patient is taking, not because he understood what you said in terms of speech. So this is something that we'll be aware. So when we test, usually we keep the bystander there, and when you tell them the commands, then they realize that actually the patient is not comprehending as much as what they think. The general day-to-day activities they are able to carry out only because of the presence of so many visual cues in the environment. Okay. Next is, can you see this? There's a connection between the Broca's and the Wernicke's area. Okay. Is this picture visible? Can you all see
Yes, it's
okay.
visible.
Okay, this is the arcuate fasciculus. Okay, so this connects the Wernicke's and the Broca's area. Sometimes it can lead to a damage in this connection. Leads to something called conduction aphasia. So isolated tasks like expression or reception, the patient is able to understand. But if you ask him to repeat after me, the clinician gives a sentence that says repeat after me, because this connection is broken, they are not able to repeat, which is the hallmark feature of a patient with conduction aphasia. So I spoke about Wernicke's, I spoke about Broca's, I spoke about conduction. Suppose the lesion is very large. I'll just go on to the next picture. So suppose the lesion is very large, it's a major infarct involving the majority of the brain, then sometimes that is when the patient cannot understand, he cannot speak. So that is what we refer to as global aphasia. That is the severest one. Okay. Then I'd also like to tell you a little bit about transcortical motor aphasia and transcortical sensory aphasia. Now, in transcortical motor aphasia, the lesion is situated a little above here, and they perform better than Broca's aphasia, especially in terms of they repeat better. Similarly, the transcortical sensory aphasia. So, for example, Broca's aphasia is non-fluid. They also are non-fluid, but they perform much better than the Broca's. Now, in transcortical sensory, again the lesion is away from the Wernicke's area, and here the patient here also remains fluent. And the difference between these two is that here also their repetition is much better than the Wernicke's aphasia. Okay, so as I said earlier, repetition is significantly impaired in conduction. And can you see these numbers? They are the Brodmann area classification that you read up, you will get to know. Okay. Broca's area and then the other Brodmann areas. They are also references, anatomical references. Okay. Okay, so this diagram just depicts pathway, and it is basically just for, suppose you're giving a visual stimulation, this is how the path goes. Okay, from here it moves here, and you can see how it goes to production. I'm not going into the details, it's self-explanatory. Okay, but one thing that we should remember is that the clinical findings in aphasias are very variable, and the language disorders do not follow anatomical landmarks. Why I say this is sometimes you can have a lesion in a similar area, but two patients have different language deficits on clinical evaluation, or you can have a patient with similar kind of language deficits, but anatomically when you image they may have damage in different areas. But whatever said and done, we have to do when we do the language evaluation, it's only then that what are the deficits that the patient has are uncovered, and it's only when we uncover these deficits and we look at them and we analyze them along with the input that we have got from in terms of the neurological signs and symptoms, we are able to localize it to a certain extent. Now, in here I would like to particularly add that in routine clinical practice, what we generally use is the Western aphasia battery, because it helps you one, to classify aphasias in terms of the type. It provides you with the severity, and it gives you an aphasia quotient. And I specifically say this because I think that all of you are now aware that aphasias and dementias have now been included in the RPD W Act of 2016, and the yardstick that is used for aphasias is usually the Western aphasia battery, and the aphasia quotient is determined and that is taken. So that is why I just wanted to mention it. And see, when you have a process of quantification, it's also it helps you to document if there is progress, if there's improvement, or if there's deterioration in functions. So that clinically it helps you. Okay, and now this is not only for aphasia, it is general. What we as clinicians and when you work with patients, you have to remember that no two brains are alike. Okay, every person is different, and every injury manifests itself in different ways, and every outcome is unique. Okay, no two individuals perform the same way. You have to very often tailor make things to suit that particular individual, and then only you will get the desired results. Okay, I talked to you about the aphasias. I also need to mention the Alexias and the agraphias. Alexias and agraphias are basically the reading writing disorders, and it's categorized based on patient's performance. Now, these Alexias and agraphias are very often missed because they are not looked into. So without deliberate testing, you cannot find this. Okay, and you should also have a history of intact reading and writing skills pre-mortally. Another thing that what is happening now is we know that actually writing is going on to a little bit of disuse, because most patients or most people now are heavily reliant on the computer. So writing as a task itself, manually writing, is but it's important. Okay, so it's important to look for these problems And it's important not to miss these problems, because they also give you clues as to where is the damage and things like that. Okay. So suppose a patient has Alexia. The patient is not able to read, but he's able to write. Okay. But see, that is also when the presentation is in the visual modality. That means on a piece of paper, visually when you show, he's not able to. But you should remember that if it is pure Alexia, if the modality is changed, suppose I trace a letter on his palm, then the patient is able to say the letter. Or if I present a word, ka, ta, he may be able to string it together and say the word. Okay. Now, this patient with pure Alexia will not have any other language difficulties. That means he will speak well, he will, be able to comprehend well, he will be able to repeat well. So, in this particular case, the lesion is in the left occipital lobe, and it may be due to a hemorrhage in the left posterior cerebral artery. Okay. You can also have an entity which is Alexia with agraphia. Now, here the patient can't read or write. It's also called parietal Alexia. And the lesion is in the angular gyrus, which I showed you earlier on the diagram. Okay. Now, the Alexias and agraphias can also accompany aphasia. Okay. And it is seen in very different forms. So, when you are assessing the reading component, you may find, I'm just giving you probable options. Okay. Probable scenarios wherein one, the patient may be only able to read letter by letter. Okay. So, for example, if the word presented was car, he may not be able to read it as car. He will be reading it as C-A-R, but he cannot put it together. That is one scenario. The patient can have what is called as deep dyslexia. What we see in the deep dyslexia is that actually, before I go on to deep and surface and phonological, I just need to tell you that people who are interested in this area may actually read up. There are many reading routes. Okay, so you can read up on that. The reading routes. There is a lexical route. There is a semantic route. There's a phonological route. So you can read certain types of words bypassing certain routes. So because I do not have time to go into all the details, I have just listed here what are the problems that can be seen. Okay, so you can have a deep dyslexia wherein the patient can read familiar words. I put /write because the same parallel is seen in difficulty in writing also. Okay, so in deep they read or they write familiar words, but they have difficulty in non-words. Non-words are words that are not, present in a particular language. There's no meaning. Okay, what happens in surface dyslexia is they can read or write non-words, but they have difficulty in words with irregular spelling. Now, those with regular spelling and irregular spelling is where that they don't follow the normal route. For example, in a word like knife. Okay, how does knife sound? When you hear it, you're hearing the n sound first, isn't it? But then when you spell it, you put the K before that, and the K is silent. So that is a word with irregular spelling. So laugh. Now in laugh, when you say it, it sounds like F, isn't it? But the UGH, so that's not regular. So those kind of words are very difficult. Malayalam also has irregular words, but it is very rare. We generally in the Malayalam language, you write the way that you say itself, you can write tamara, tamara, like that. That's just an example that I gave. Okay, so that is surface. In phonological, what happens is that if you give them a word, they cannot break it into the individual sounds. So these are the patterns that are generally seen in the aphasia Alexia. I told about the reading. The similar problems can be seen in writing also. Okay, now I just wanted to demonstrate here. I'm just showing you an example of one of my patients. Can you see this writing sample? Is it visible?
Yes, ma'am, it's visible.
Okay, so if you look at it particularly, there is some overwriting. There is also a mixing of the upper and lower case, if you have noticed. Then the patient was not able to write to, if I said anything, see, a writing task, usually when I take from the Western Aphasia battery, will include writing of address, it will include writing to dictation, writing, I will show them a picture and ask them to write about the picture and things like that. So, this was at baseline. What I mean by baseline is the first time the patient came. Now, this was a case who had aphasia consequent to stroke, and he was a young individual, a 37-year-old individual, and he was proficient both in Malayalam and in English. Okay, so this was a sample at baseline. Now, we gave him therapy, we worked on several aspects, and now you can see. So how do you think the writing is now? After 3 months, we are seeing a change, isn't it? The patient is able to write to dictation. Things like he was not able to describe the picture. Now he's able to describe the picture. The handwriting, the orthography of the letters have improved and they become more legible. There is no mixing of upper and lower case. Okay. So this is because we have specifically given therapy to the patient and he has improved. So this definitely from the previous situation, after 3 months, the patient has definitely shown a change, and this is how his performance is. Okay. Okay. Now, I also wanted to just give you an example of the type of reading errors that were seen, not in the same patient, in another patient. Can you carefully look at that? I've written the target word on one side and the response on the other side. So, when the word was here, it was read as hair, paste was read as past, plain, pained, then him was hum, bled was blade. So you can see there are additions, there are deletions, and the clam was made calm. Sometimes unfamiliar words are made into familiar words, read as familiar words. Seas becomes size, take becomes tea, topic, simile becomes smile, which is a more familiar word, lose, loss, scarce, and scare. So there are omissions and deletions, and there are substitutions of words into more familiar ones. Okay. So that was the errors. Okay, so that was basically, I just spoke to you about the aphasias, I spoke to you about the Alexias and the agraphias. Now I'll slowly move on to dementia. Now, if you ask me the question, is language affected in dementia, is impaired in dementia? Then the answer is that yes. And what happens in the early stages is that if they are very early, the language deficits are very, very subtle. Actually, sorry, I think I missed one thing in the aphasias. When I told you the type of aphasias, you should remember that if it's a very mild aphasia, sometimes the patient only has a naming deficit. Okay, that means he cannot name objects. So if you show him a pen, he will say, "This is this is what I write with," but he cannot say the word pen. Okay, so that is anomia. So that's just the mildest form of aphasia. And another thing that we should remember is usually during recovery, as the patient recovers, suppose he's very severe or he has a broca, the end stage is usually anomia. So they finally they may have only little bit of anomia after 6 months or 1 year after the stroke. And so that's something that I missed out. I should have said that earlier. So similarly, in dementia, what we see is that in the initial stages or in the mildest form, usually what we see is that the patient will only have a naming difficulty. He starts with a naming difficulty. Okay, but as the dementia progresses or worsens, what we see is that the other aspects start getting affected and the content reduces, the vocabulary reduces, and when we go to the most severest form of dementia, what is seen is that the patient's speech, they become withdrawn, they're very quiet, they just communicate basic primitive needs, and sometimes they even become very mute. Okay, so what we should remember that is that in generalized dementias, usually the language disorders are seen along with the other nonverbal memory deficits, or there may be right hemisphere tasks being involved. So it's a more, a widespread involvement. Okay. Now I'd like to talk to you about something more focal. Okay, because what is seen is that sometimes, and today I'm not talking about all the types of dementia, but I'd like to specifically talk about primary progressive aphasia. Now, why I have chosen this is that it's not a generalized atrophy. Here, it's a very focal atrophy. And when it's a focal atrophy, here what happens is in primary progressive aphasia, it leads to a very selective disorder of language. And there is no history of stroke, there is no history of tumor, but then the patient will present with a difficulty in language. And interest in this area of primary progressive aphasia was by work by Messelem in 1982, and they had classified it as when the patient presents with a deterioration in language for at least 2 years without deterioration in other cognitive domains, there was a possibility that the patient had primary progressive aphasia. This was further revised and made 1 year because they did find there were reports in literature where the deterioration in language was only for 1 year and the other cognitive domains started getting impaired after that. Now, why we have to take particular care in this disorder is that, again, here, just like the aphasia, I had said the Wernicke's and the Broca's is fluent and non-fluent. In primary progressive aphasia, also we have a non-fluent and a fluent variety. Okay. Now, how do these patients present? They present clinically with difficulty in finding the right word, and there are no other cognitive difficulties. But relatives always feel that it is a memory complaint rather than that of language. It is only when you ask very, very specific questions that you get the history properly, and it is on this probing and evaluation you know that in the initial phase it was only language. So when you take a history, they will say ormakoram or memory difficulty. So then you will say for what? So that time they will say, are they misplacing objects? Did they forget that they kept things? Things like that. They'll say, no, it's not that. They couldn't get names of the son or the child. So it's more of a naming thing per se. Okay. So basically, I told you there are two forms, which is the fluent and the non-fluent form. And in the non-fluent form, I'm just going to list out the neuropsychological profile here and the language profile so that you people will get a better understanding. Now, in the neuropsychological profile, what you see is that the patient has preserved insight. He knows that he's struggling for a word, and that struggle is so is so evident, and the patient feels extremely frustrated. He is upset that he cannot get the word, and you will see him. He will, make expressions like, that I'm not able to get it. He will try to communicate it with you that I'm struggling. I'm not finding the word. Okay, and his language is non-fluent. The calculation is preserved early, perception is preserved, spatial abilities are preserved early. He will not have wayfinding difficulty. Okay, and he will have very good non-verbal memory, the patient, and the motor skills are preserved early. In terms of language, the speech I said earlier is non-fluent. It's agrammatic. And they have difficulty with repetition. They have difficulty with naming. It's more of phonemic paraphasias. And they do on the animal fluency, they do better than the letter fluency. I'm sure you people are familiar with category and letter. They also have difficulty naming verbs rather than nouns. And the comprehension is quite preserved. They understand what you say. They will follow commands. And you can have difficulties in the reading writing task similar to how your spoken language is. Now, in semantic dementia, performance is consistent, but the patient has impaired word meaning. They don't understand the meaning of some words. For example, during testing, I remember that when I gave a picture pointing task to a patient, when I put an array of cards and I gave a task of pointing out to animals, and I told him to point to cat, he just looked at me and he asked, what is cat? Okay, so he had lost that from his vocabulary store. Now the calculation is preserved, and they have difficulty in face recognition. We did have a patient who, was having difficulty recognizing his son, his wife, like that. And the spatial skills are again preserved, construction skills are preserved. They have good autobiographical memory. You ask them things about themselves, they will, say they will recollect very well, but general knowledge is basically impaired. That's because the semantic store is actually eroded in this group. Okay, in terms of the language characteristics, they present you as very fluent speakers, but there are semantic paraphasias. So they can substitute words. For example, you can call potato as onion as potato. That is just an example. Again, they can repeat the naming. They have semantic errors. Now, what you should see here is that it's the reverse of the previous, wherein here they do letter better than category, and they have difficulty naming nouns than words. It's just the reverse of the non-fluent variety. And again, here comprehension is difficult in terms of it because there's a loss of word meaning, but they do understand some grammatical aspects. And reading is fluent, and writing is also fluent in semantic dimension. So now when you compare the two, it's like two sides of a coin. You have one is fluent, the other non-fluent. In one, we have impaired semantics. The other one, we have phonology being impaired. One, we have preserved phonology. The other, we have semantics preserved. One has semantic paraphasias, another has phonemic paraphasias. In one, the digit span is preserved, and the other one, digit span is impaired. And then letter better than category, and category better than letter in the non-fluent variety. Okay, so this is just for you to be aware that primary progressive aphasia presents in two different forms, and these are the characteristics. Okay. Now, in this particular condition, you know that it's a degenerative condition, so it's important to make an early and accurate diagnosis. It's important to supplement the neuropsychological test with language tests in early diagnosis, because as all of you know, in dementia, a lot of neuropsychological tests are, but in this particular patient, you need to supplement it with language tests. And when you are able to, give whatever findings you have, both in terms of the language evaluation and the neuropsychological evaluation, and when we put it together, the treating physician is able to prognosticate, he's able to recommend further investigations, and he's able to counsel the family. So that's extremely important, and that is a role that we all have to play. Okay. So actually, when we started seeing patients, we actually developed something called a semantic battery, because we did not have adequate tools to actually look for this disorder, especially to differentiate between them. We had to develop a semantic battery, and the findings of that have been described in this paper. If any of you are interested in it, you can, of course, it's one of our earlier papers in 2005, we have published it. So you can read about primary progressive aphasia, and we have compared the non-fluent aphasia and semantic dementia. So this was work done at Sri Chitra, and I think it gives an excellent case description, especially for students. I think if you can read this paper up, it will be good, so that you will be aware of how they present, and it will help you to differentiate between the two. Okay. So that was the objective of me in terms of telling you about primary progressive aphasia, because very often erroneous diagnoses are made, and it is important that if you're using the correct battery of tests, you're able to help the clinician in arriving at a correct diagnosis. Okay. Now I'm moving on to another area, that is language and cognition. I'm not going to go into the depth, but then it's a question that has, been behind a lot of minds. Okay, but we should remember that it is it related? Yes, it's related. Language allows us to talk about what we see. It converts visual representation into linguistic representation, and hence it plays a very major role in human cognition. And it's related to higher mental functions as well as to the functions such as attention and working memory. Okay, so I'm just going to tell you some basic terms, so that when you get papers related to language, you should know what it refers to. I already described what language is. I also want to say what is semantics. Semantics basically refers to meaning. Okay, so you can put words together, and if they are not, and these words only if they make sense, you will say that there is meaning or you understand them. Okay, then there's something called phoneme. A phoneme is the smallest unit of sound. Ma, pa, ka, like that. Morpheme is the smallest unit of a word, and syntax refers to grammar. Okay, now why I would specifically like to talk about just an extra sentence about syntax is that word order is very important in our languages. For example, if you say the boy ate an apple, or the boy is eating an apple. Okay, so we have subject S, then we have eating, which is the verb, and then we have apple, which is the object. So it is English, we use the SVO order. Okay, then in our regional languages, for example, if you take the case of Hindi, ladka seb khata hai, avan apple കഴിക്കുന്നു, or avan apple തിന്നുന്നു. If it is like that, what happened is the object position has changed. So in our regional languages, we do not follow the SVO order, we follow the SOV order. Now when that happens, when the grammatical order, so this grammatical order is important, and it is language specific. Okay, so I am making a specific reference here to that for the reason that, like I gave you this example, when languages, when adaptations or translations are done for tests into regional languages, we have to take particular care. If it is confining or conforming to the rules of that language, is the word order the same, is it allowed, is the construction allowed in that particular language, are things that have to be taken into consideration before adaptations are made on tests. Okay, then another term which is generative. Generative refers to the number of, we have an infinite set of utterances which are made into finite set of elements based on the rules of the language. So we are able to construct it and make it into, we can have a simple sentence, we can have a complex sentence, and man has, we use language and we are able to, use the language and transform it into very many different structures, keeping in mind the rules. Okay, so this was just basically for you to know the terminology, so that in case you come across this terminologies, you know what it refers to. Okay, this the picture is self-explanatory. We all know that left brain is dedicated to certain functions and the right brain is dedicated to certain functions. But today I would be particularly interested in talking to you about cerebral dominance, and specifically for language. So from the time of Paul Broca, they did understand that language was, the left hemisphere was important, and also that it was on the opposite side of the preferred hand, because they knew that if the patient developed paralysis on one side, there's most likelihood that the language was on the opposite side. And as we all know that left hemisphere is dominant for language in most individuals. Okay, and we also know that a majority of the population is right-handed and 15% of the population is left-handed. Okay. Now, it is also very, very important to ascertain handedness during the evaluation. I have written here language evaluation, and it's also applicable to your background also. And because the dominance of language is related to the patient's handedness. So it's important to ask if they're right, if they're left, if they're ambi, or if there's a force shift because of family or social pressure. Now, a family history of sinistrality or ambidextrity is documented as dominance is strongly affected by hereditary factors. But, in my clinical practice, what I've usually seen is, I have this question on my case history sheet, which says family history of left-handedness. And whenever there is a developmental language disorder, we do find that there are higher chances of a family history of left-handedness. Okay. The thing is that till you ask for it, nobody is going to volunteer for that information. And I'm sure that all of you are familiar with the Edinburgh handedness inventory. So, especially in clinical situations, like when I go on to the next slide, you will understand why I'm talking about it. It's important to document it. Okay. So, now this getting this information documented is important in patients who have focal cerebral lesions and will have to be subjected to surgical procedures. Now, we have patients with tumors who need resection, or we may have patients who are going to undergo surgery for temporal lobe epilepsy. So, what happens in these patients is, am I audible? Hello? Hello?
Yes, ma'am, you're audible.
Okay. Yeah. Okay. So what happens in this? No, the thing is that because I can't see you, no, so I'm not sure if I'm audible or not. Okay. No, fine. Anyhow, so the thing is that it's again in this particular case, it's important because it helps in prognostication and decision making. Okay. Because the surgeon would like to know prior to surgery where is where is the language area, and also sometimes they would want to find out about how patient's memory is or how the motor areas are and all that. Okay, so usually the commonest thing that we do for determining cerebral dominance for language is a WADA test. If you are not familiar with that, you can read up on that, or a functional MRI is done. Okay. Now, while we were working at Chitra, I think we did, or we were fortunate enough to, we were able to develop paradigms to study the language and the language aspect, and I think the memory paradigms were done by our neuropsychologist. So, with that, we were able to study patients. Of course, we did have a protocol for language testing and memory testing for the WADA test. So now, when this is done prior to surgery, it has benefited several patients and it has helped to reduce post-operative deficits, because if areas are marked earlier, then the neurosurgeon can go in with certainty, and he can also tell the patient prior to surgery that there's what is the likelihood of the patient developing deficits, or even the neurosurgeon can be very careful in terms while he's resecting, so that he will know how to minimize post-operative deficits. Okay, so that is the importance of that. Okay, so I just want to show you this scan, and you can see here that the patient was a seizure patient, and the patient had developed postoperative gliosis. And when we did the language evaluation, what has happened? Can you see? The language was lateralized to the right side. Okay. The language was lateralized. These were two tasks. That's why you have two images. It's two different tasks. And what about the hand area? So when the motor task was given, the patient was asked to move both his hands, and then he was scanned. What was found is that, can you see here? Can you see this? Now this very close to the lesion. So in this particular case, post-operatively, the neurosurgeon could counsel the patient and tell the patient and his bystanders that following resection or following intervention, the patient will definitely not have any difficulty with language, but he will have difficulty with with his hand function. He may develop a paralysis or a paresis of that limb because it is very close to the lesion. So this is just an example, or this is just an illustration of how they have used it for so the importance of finding out the cerebral dominance for language and for the motor task, so that this is helped in preoperative counseling. Okay. Now I'm now moving on to another aspect, and this aspect is in terms of the clinical evaluation. So we know that it's a basic tool for communication, and it's crucial for the patient's functioning and in the assessment of cognitive functioning. But what we all have to bear in mind and take care is that the integrity of language functions should be evaluated early in the course of the mental status examination. The reason I say that, you have to be very careful while administering verbal tests to individuals with language difficulties. Okay, so what you see is that individuals who have difficulty in performing the verbal test may do better on the non-verbal tests. Sometimes they may not be able to do the test because they have difficulty in comprehending the test instruction. So, for example, if the patient is not able to hear the instruction, you may have to use another modality to provide the test instruction. Now, if you don't follow this or you don't take this aspect into consideration, it will lead to erroneous interpretations and we will be making wrong clinical diagnosis. So at any time, if you find that the patient has difficulty in language, it's always better to get the language evaluation done by a qualified SLP, so that these problems are circumvented. Similarly, as when I talk to my SLP students also, I do say that is whenever we are all a team, we are all working for a common cause, and that common cause is the betterment of the patient or the benefit of the patient. So referrals to and within the team are always welcome. Okay, so there are certain areas which I work in, there are certain areas that you work in. So you have to have a good understanding as to what are the areas that we can help each other, and what are the lines that we keep and what are the lines that we don't cross. All these things are important, and each of us will work together as part of the team to help the patient and to rehabilitate him. And I think the objective is to get him back to his full capability and functioning in society. That is the ultimate aim of any rehabilitation professional, and that is possible when we all work together. So if we keep these small things in mind, we can go a very long way. Okay, because when the patient comes to you at the clinic, he may appear very normal at the superficial level, and it's only when you formally test the patient that you see the deficits. So considerable information about the client's cognitive or language status is ascertained during history taking itself. So basically, case history taking is an art. One should ask the right questions to obtain the right answers. And the clinician should be highly observant. Like for the example of handedness, what I was talking about is, till you ask for it, they are not going to volunteer that information. Okay. Similarly, I think all clinicians from any background, be it speech pathologists, be it psychologists, be it occupational therapists, I think we should all be good listeners. Okay. Only if you're good listeners and you should have a good set of soft skills, only then patients will cooperate with you and patients will actually tell you what their problems are, and you will be getting a total picture of the patient only if you are patient enough to spend time with them and ask the right questions and get the right answers. Okay, so that's also another small tip. And it's also important to know the educational status of the patient, and because that a lot of the tests is how they perform. The influences are the responses are influenced by education, and it's true not only for language tests, it's true for most of the psychological tests too. Education is an important factor. Then very, very important, it's important to cross-check if the individual uses a visual or hearing aid or if he or she has brought it to the clinic. Why I'm saying this is that mistakes have happened wherein reading material have been given to the patient when he was actually a patient using a visual aid. You may make again erroneous interpretations because the patient has not used his hearing aid or a visual aid. So and it's important before you do any reading writing tests to cross check if the patient has brought the aid. If not, you have to schedule it for another day, and only then will you get the right results. It's also important to ensure that the test environment is well lit and noise free, and it's important to, if it's a very long test, you have to give them breaks in between. But I would always say go by the manual, because in case you give too long breaks also, it may influence the results. And I think to all the young students who are listening here, a test administration is something that you have to be very precise with, and you have to follow what are the guidelines that are provided in each test on test administration, and you cannot divert, or the minute that we divert, we lose the quality of what we are doing. Not only that, what happens is that there's no uniformity in the results that you got if your test administration has not been right. Okay, now I am going to move on to the last part of the morning talk, and that is future. Okay, so when I did talk to you about the brain areas, and I did talk to you about their aphasias and all, a lot of things have actually moved on and changed in the last 20 years. And there's a lot of research into the neural basis of language processing. So I'm sure that many of you have seen this textbook, right? The Gray's Anatomy. Gray's Anatomy is a very famous textbook, anatomy for medical students. So why I selected this picture is that I'm sure that you remember that a few minutes back, I did show you the arcuate fasciculus, isn't it? So you saw how I had shown that picture. So compared to that picture, now this is what is on the cover of the Gray's Anatomy textbook, and this is how the Gray's and the arcuate fasciculus is now being depicted, because now we have, with the advent of neuroimaging, so much has changed, and our understanding of a lot of things has changed. Okay, so like I said, these advances in fMRI, electrophysiological studies, TTI, TMS have provided insights into the relationship between brain and language, and we have understood that a task relies on a complex set of cognitive processes carried out by a network of neural regions working together. So that's where the changes come. All the emphasis now is on networks. So any paper you take now, or at least for the last decade or so, most of it has been talks only about networks. So even how aphasia has been portrayed has changed from description of language tasks impaired by a brain to describing the disruptive cognitive processes underlying language. Okay, and while this work on neuroimaging was going on, they did find out that there's individual variability in the boundaries of the fields that are identified by Brodmann. I showed you a picture where there were numbers, right? The Brodmann areas. So when they mapped the areas, they found that when there were certain specific deficits, there were differences. Also, they did realize that whenever there was an infarct, it is not only that area, but areas surrounding that will also contribute to the deficit. So they also found that vascular territories or areas which are supplied by particular, they all were showing that whenever there were deficits seen, there were dysfunctions to areas that were supplied by a particular territory. Okay. Similarly, the other findings that were seen that you can have a particular function, but it can be represented by different areas of the brain, or different areas in the brain can provide different areas could be affected, but you could see a same deficit in patients. Okay, so every area has a series of overlapping networks. So sometimes if there's a single lesion, there can be multiple deficits and vice versa. Okay, and sometimes if many components are involved, then the deficit is more long lasting. So that is what the findings of recent research has been made. Okay. Now, can you see this picture?
Yes, ma'am.
Okay, so this is the this is something that is going on currently. It is called the Human Connectome Project. It's basically that it's a project which is dealing with studying the structural and functional connections of the brain. Okay, that's a big project that is going on. It's a multi-centric project, and as you can see in the first picture, they've used diffusion imaging too. This is the architecture of the human brain. And what they've done in the second picture is that they've reconstructed this and they found the connections. And they found that majority of the connections was in the middle of the brain. So they are starting neonate brains and adult brains, and they are trying to find out both in typically developing brains, or like in the normal individuals and individuals affected by disease. So I just wanted you all to be aware, so you can read up also. So these are the things that are happening now. Okay, so I would like to conclude this morning session just by letting you know that a lot of things now have changed, and our understanding of brain and language now currently has changed, and it's only because of neuroimaging. It is only because of lack of time, otherwise I would have been happy to actually just describe to you all a few bits of neuroimaging, but then because we didn't have the time, it has not been included, but I'm sure that all of you can read up about it. And today we have evidence to suggest that recovery takes place following intervention. And that was possible only because of this explosion in terms of research that has happened in this last decade. Okay, so my next lecture will be in relation to recovery and plasticity. And the reason that I have chosen that topic is because of the question that does rehabilitation help, or does speech therapy work, or cognitive therapy work, is a question. So today we have evidence to suggest that yes, it does work, and what are the changes, and it will help us to explain to our patients better too. So that is the next part of my talk. So I hope that I have been able to convey a little bit about what I wanted to say, and it's been in your minds. And if there are any questions, I'd like to take. Hopefully I will answer to the best of my ability if it's in areas related to my work. Okay, so I'd like to conclude my first session by saying that the only place where success comes before work is in the dictionary. So always, I think we need to work hard. Okay. Thank you all for your patient listening.
Thank you, ma'am, for the informative session. We shall now move on to the question answer session. The first query is from Gopi Krishnan. Whether the hand dominance affect the language laterality?
Actually, I cannot. 1 minute. Just a minute. Yeah. So the question is whether hand dominance affects the language laterality. I don't know if Gopi, you missed that bit where I did say that we have right-handed and left-handed individuals, isn't it? So 85% I said were right-handed. So in most individuals, we are having the language lateralities in the left hemisphere, and in some individuals, which it is if they are left-handed, it can either be in the same hemisphere or it can be in the opposite hemisphere. We also have individuals who have bilateral dominance. That means it's not well established.
Thank you, ma'am. The next question is again from Gopi Krishnan. People with congenital visual disturbances find it difficult to process language at first. Why so?
Okay. What I'd like to say here, Gopi, is that probably is how do we learn? You learn through all modalities, isn't it? During development, We learn through all modalities. So when you learn through all modalities, when one is compromised, be it hearing, be it vision, any of it, that is lack of input from a particular modality. So when you are developing, it is very, very crucial, very crucial to have all the modalities intact. In this particular case, when you say that the visual modality is compromised, they have this difficulty because their input system is not getting things adequately.
Thank you, ma'am. The next question is from Rakshita. So people with Broca's aphasia will be able to comprehend that they aren't fluent, but people with Wernicke's aphasia will not even be able to understand that they're speaking fluent nonsense, right?
Very true, Rakshita. And sometimes they feel that we are the bystander or the caregiver or the clinician is the one who's not understanding. That's how the Wernicke's aphasia feels. They don't realize that they have a problem because they don't have insight.
Thank you, ma'am. Next question is from Dr. Pisharidi. Children with language delay are especially delayed in expressive language. Many of them experience learning problem later, even if there is catch up in speech. Can we take this as a maturational delay? And they are likely to catch up in learning also if we wait a little more for formally introduced to schooling.
Historically, sir, actually, when we document, what we see is that suppose I see a child late. I'm giving an example. Like suppose the child did not come to me earlier, but he came to me while he was at school, and he did have difficulty in learning. What happens is if you trace back the history, very often the child would have had a delay in expressive language. So we always caution when individuals are brought to us or when children are brought to us in the beginning, even before schooling, in the preschool stage, and they have a history of an expressive delay. We do caution parents that there is a likelihood that the patient may have some sort of learning problem in school. So please watch out for these problems, and they need to be brought back, and they need to be helped with these problems. And they have a greater percentage of children with delay have a greater percentage of having these learning problems later. In terms of, I think the second part of your question, can we take this as a maturational delay and some more weight may improve their learning problems if we initiate them to formal teaching a bit late? No, sir, I don't believe in that. I feel that there's no weight. Like whenever we identify it, earlier the intervention, the better.
Thank you, ma'am. We have another question from Dr. Devi. Ma'am, what kind of therapy and training can be given to patients with aphasia and agraphia?
Okay. And Devi, actually, before I answer your question, this entire subject of aphasia is probably covered over 1 or 2 semesters in our course. So, I could not put everything together here today to just tell you because it will probably take the whole day for me. But I would simplify it in the sense for each type of aphasia, the methods that we use are different. So, for example, I may want to work more on the use a visual modality to work with my Wernicke's aphasia. I will want to improve the fluency of my Broca's aphasic. Similarly, if my anomic is having a naming difficulty, then I may want to work only using a technique called deblocking. So based on the type of aphasia, we have different techniques. Similarly, if it's a very, very severe problem like a global aphasic, or he may not start off with expressive speech, I may use some other modality, which is something like a PACE, which I may use, or I may use a AAC, which is an alternative mode of communication, so that in the beginning stage, the patient has some form or some modality of expressing himself rather than his forcing him to depend on the expressive component. Now, in terms of agraphia and Alexia, actually, it's all dependent on the baseline of the patient. So after I do the formal assessment and I find out what is the type of difficulty that they have in reading and writing, I have to tailor make my session just for that. Okay, so in some patients, like for example, when you have weakness of the right side, then I have taught patients to start writing with the left. Okay, and believe me, their left writing was much better than my right-handed writing. Okay, so it involved something like very, very simple tasks, for example, copywriting and things like that, going on to things, writing to dictation, and then writing about picture description or passages. So based on each individual, I have to tailor make it and get them to work on the Alexia and the agraphia.
Thank you, ma'am. We have the last question from Dr. Bibhuti Biswal. How morpheme is linked to cognition?
Okay, sir, I'm actually probably I'm not the best person to answer this, but probably what people from the research aspect, or those who are working in the who are looking into the developmental research, would be able to answer this question better. But as it is a component of in language, it is the smallest component of the word morpheme. So a lot of work has been in terms of in terms of the reception, and it's also been used in the reading writing studies. So I feel that probably they will be in a better position to answer that question.
Thank you, ma'am. That was the last question. Thank you for answering all the questions. Now I request you all to make sure, having filled the feedback forms, and we will be having a lunch break, and we shall resume the afternoon session at 1:30. Thank you all.
Okay, thank you.
Thank you, ma'am.